once again for all the support you have been giving for this program. We know it's coming much closer to your exams now. That's the reason why we are having this program almost every week. And each one of you has a similar programs which is going on across the country, and we'll be concentrating on that. To pick up material from all these programs and compile them and use it for your exams is going to be a key for the next 1.5 months. I think some of you are taking your exams in November, and there's another group of doctors who are taking their exams in January. So these programs, I hope, will be very useful to you. And as we assured you, these programs are now being uploaded in our YouTube. Of the 6 programs which have been done so far, 3 of them are already uploaded in the YouTube. I'll give you the YouTube link shortly by tonight so that you can have an idea about all those programs people have missed also for this. Today, we have localized carcinoma prostate. We have 2 wonderful examiners, Dr. Amlesh Seth. He is the professor and head of the department from AIIMS New Delhi, someone who does a lot of uro-oncology work. And we have Dr. Prashant Nayak from AIIMS Bhubaneswar, the professor and head of department, who is also included in one of the best uro-oncologists in our country. So we have 2 very good urologists and uro-oncologists who have specifically come for this program to you. We have 2 candidates, Dr. Durva from Bijapur, and we have one more candidate, Dr. Anand, who has come from Jaipur. And as usual, our presenter today is Dr. Surendra Anbu from Chennai. As we know, we place it in such a way so that it goes easily and smoothly, and there is not much of interference of discussion between the candidates. So I have requested Dr. Durva to take the first history component, and I have also requested Professor Amlesh Seth to do the history component for you. And once it comes to investigation, Dr. Prashant Nayak as well as Dr. Anand will contribute to the investigation component. And once management starts in, all 4 will chip in. And as usual, I'll stay as a moderator away from you. But whenever it's necessary, I'll just come in as an internal examiner to you to add a few points or add a few places where I can help the candidates. So can we get it going? Professor Amlesh Seth, sir, over to you.
Okay, Dhruv. The history will be presented. This is like a ward round exercise, and normally it is held in the physical way, but today it will be online. Okay, so go ahead and so this is the history. This is the first one.
Yes, sir.
Okay. So what are the most important points that you would like to emphasize on?
Sir, in this history, sir, first I would like to see the age of the patient, sir. Age of the patient, and then he's come with mixed lower urinary tract symptoms, sir. He's having straining to void, poor stream, and frequency nocturia. One more significant history is he's had history of catheterization previously, and he's having bilateral hip pain too, sir. So these are the significant points which I would like to look, and I would also like to look at hematuria, lithuria, incontinence, which he doesn't have, sir, actually. And apart from that, any flank pain, fever with chills, which is not mentioned here. Along with that, I would also know more about his family history and personal history, sir.
Okay, do you think this history is complete, or there are certain other issues that you would like to know?
Sir, here hematuria is mentioned. I would like to ask about any flank pain associated with this, sir, with this flank pain and lithuria, sir. It's not there.
Okay, no history of calcaluria and
yes, sir, it's mentioned. I will also ask about other history like any cough, hemoptysis, and they have not mentioned that. But with initial mixed bloods the patient is presenting with, this would be the initial history which I would ask, sir.
No, there is one point which is very important, and that has not been detailed. He had a history of catheter insertion and drained 600 ml of urine.
Yes.
But it is not mentioned when When did he have this catheterization? And was it a single time catheterization? Was it kept indwelling? And what were the symptoms that he had before? And what are the symptoms that are persisting after?
Yes, sir.
Now, with this, what will be our differential diagnosis?
Sir, with this, I would like to give a DD of bladder outlet obstruction secondary to enlargement of prostate, probably a benign enlargement of prostate or a malignant CA prostate, sir.
So your first diagnosis would be BPH.
Yes, sir, BPH,
And in
sir.
differential diagnosis, what other things will you include?
Sir, stricture urethra vesicle calculus would be my other differential diagnosis, sir. But they would come after CA prostate, sir. BPH, CA prostate, stricture urethra, and vesicle calculus, sir.
If a 68-year-old man presents with voiding or storage symptoms,
Yes, sir.
in what percentage of patients will you find BPH as the diagnosis?
Almost 40 to 60% of the patients will have storage mixed blood, sir. Basically.
No. My question is the other way around.
Put it down in a house.
If there is a 68-year-old man
The reports.
who presents with these symptoms, a mixture of voiding and storage symptoms, in what percentage of patients will BPH be the main diagnosis or the only diagnosis?
Not sure, sir.
It's a very simple question. You just have to give a percentage.
Yes.
Rough percentage. I mean, obviously, I don't want you to tell 76.34% or something like that.
Around 60%.
60%. Okay. So what will be the differential diagnosis in the remaining 40%?
Sir, it can be a vesicle calculus.
In your experience,
Yes.
in your OPD, if you have been sitting there and seeing so many patients, you will find 40% of patients having diagnosis other than this. Okay, apart from the diagnosis that you have mentioned, what are the other diagnoses that you have come across?
Sir, we have come across any neurogenic bladder also, sir, with mixed lower tract symptoms in this age group. Then
Neurogenic bladder due to what?
Neurogenic bladder due to one is it can be a diabetic cystopathy, sir,
Yes.
or yes, sir, and intervertebral disc pathologies because of age related.
Yes. Lumbar disc pathology.
Lumbar, yes, sir. Yes, sir.
Thoracic disc pathology.
Yes, sir.
Yes. Okay. What else?
Chronic bladder outlet obstruction with decompensated bladder.
No, I am talking about other diagnoses that you have seen.
Yes, sir. And apart from this stricture urethra, sir, we have
So
seen.
that you already talked about.
Yes.
Have you come across patients with compulsive polydipsia? What is compulsive polydipsia?
Increased water intake, sir,
Yes.
with an intention to
Yes.
empty the bladder. So
Yes. So there are patients, who will keep on drinking 4 liters, 5 liters, 6 liters of water.
yes,
They have been watching some TV programs or radio programs, and they have been told that or some health related things, and they have been told that they need to drink more water, and they are over enthusiastic and they drink 5 or 6 liters of water. So what is the clinical history in those patients?
one is increased water intake, and one more is they would have had 1 or 2 symptoms of lower tract symptoms, sir, which would have made them consult someone, a non-medical professional who would have suggested them.
So what are the main symptoms in such patients?
Sir, they'll have frequency both daytime and nighttime also, sir. They'll have nocturia more, sir.
And what else? Yes, with the age they may develop urgency, urge incontinence also.
Yes.
In younger days, they may not develop urgency, urge incontinence. They may have just frequency and polyuria, and they will not be as bothered. They may be able to sleep all through the night. But as the age keeps on increasing, even with minimal enlargement of the prostate or minimal bladder changes, they will develop urgency, urge incontinence. Okay, tell me, what are the points in IPSS score? And what is the minimum IPSS score and what is the maximum IPSS score?
Yes, sir, we have frequency, urgency, nocturia, poor stream, intermittency, sense of incomplete voiding, and straining to void as the components of it is a AUS symptom score with the quality of life added to the to become IPSS.
So how many points are there and what's the minimum score and what's the maximum score?
Yes, sir. Total 35 out of 35 we grade it as mild, moderate, severe, sir. Up to less than 7 is mild, 8 to 19 is moderate, and 90 to 35 is severe, sir.
Is there anything like less than 7?
If he has only one or two symptoms, that to less than half of the times in a day, his score will be less only, sir.
So what score will you put in the mild category? What score will you put in the moderate category? And what score will you put in the severe category?
Yes, 1 to 6 is mild, sir. 7 to 18 is moderate. 19 to 35 is severe.
And along with that, if you add quality
of life, yes, sir. Quality of life, again, we have 5 total from 1 to 5. We have 5 points, sir, depending on the satisfaction and bothersome to the patient caused by those symptoms. Maximum is 5, sir.
Okay. Now, what do you think is the significance of bilateral hip pain in this particular patient?
Yes, sir. Sir, he's a 68-year-old male with mixed lower tract symptoms with bilateral hip pain. I would think probably if he's fitting into that malignancy age group, bilateral hip pain, probably he might be having any metastasis to the hip joint. That is one possibility. And one more possibility is age-related.
What are the common sites of metastasis from prostate cancer?
Sir, the lumbar vertebra, sir, and the pelvic girdle.
Yes, lumbar vertebra and pelvic girdle are much more common than hip.
Yes, sir.
So bilateral hip.
Probably age-related bony disease also can be there, sir. Diffuse osteoporosis because of age, that can also cause bilateral hip pain. And he's a farmer by occupation, sir. He'll be involved in more heavy weight lifting. So probably that can also cause.
Okay, so let's go to the next slide.
Personal history, he's been a smoker for 25 years, 2 packs per day, and an alcoholic for 25 years, sir, occasional alcoholic.
So how do you calculate pack years?
Sir, pack years is number of packs per day into number of years of smoking, sir. So his 2 packs per day into 25 years will be 50 pack years, sir.
Okay.
So
past history.
No history of diabetes, hypertension, coronary artery disease, no previous medical or surgical illness.
Okay. So from history point of view, you are totally satisfied, or you would like to know?
Family history, nothing significant.
So now I'll ask the same question from Surendra. Surendra,
sir,
when did he have this episode of retention? And was it a single time catheterization that he had? Or did he have an indwelling catheter for a few days? What was the exact story?
Sir, the patient had an episode of retention 3 months back, for which he took treatment in the nearby private clinic. So the doctor catheterized the patient, and the patient have a drained the urine. Because of a patient was not willing for continue the catheterization, they removed on the same day. Then the patient from the next day, the patient was normal on a normal voidings.
Okay. And was there an increase in symptoms or reduction in symptoms?
Sir, the patient is having only symptoms for the past 1 month, sir. Before, in between the
But you said that he had a catheterization
and
3 months back.
3 months back, between the 3 months to last 1 month, he doesn't have any symptoms.
So, Dhruva, tell me, is there any significance of all this?
Yes, sir. One is duration of catheterization, sir. He had catheterization only for 1 day. And chances of him developing a stricture due to catheterization of 1 day is a little less, sir. Not.
But his catheterization was 3 months ago, and his symptoms are there only for 1 month.
Yes, sir.
So, timing wise?
Sir, I would also like to ask if he's on any other drugs apart from alpha blockers, if he has taken any other anticholinergics or something, any parasympathetic lytics or those kind of drugs which can precipitate this symptoms, because the symptoms appeared after the catheter was removed.
Okay, so the drug history. Surendra?
No significant. Patient doesn't have any significant history in the past, sir.
No, he's not on any drugs. The question that he's asking, is he on any drugs?
No, sir. He doesn't have any drug intake history, sir, in the past.
Okay. So he's not taking any drugs?
He doesn't have, sir.
Okay. So was his IPSS score calculated?
Sir?
Was his IPSS score calculated or AUA score calculated?
Sir, we calculated his IPSS score, sir. It was 21, sir.
21.
Yes, sir.
Yes.
Okay. So he is in the severe category.
Yes, sir.
So now, okay, management we have to talk later on. So I'll stop here. And now we have to go to the exam. Or examination is also my part.
Yes, for examination also you do, sir. After that, Anant will
Okay.
come to me for the investigations.
Okay, okay.
Yes.
Okay.
General examination is conscious oriented, averagely built and nourished, pulse rate 78 per minute regular, blood pressure 128 by 80 millimeters of mercury, afebrile, no pyelorectus, lymphadenopathy, pedal edema, ECOG score is 1.
So what is meant by ECOG score of 1?
Sir, it's basically a score to calculate the performance status of the patient, sir. So one is he can do his own activity without any external aid or help, routine activities. So that means a good performance status.
Is there a ECOG 0 also?
No, sir, it's 1 to 5, sir.
And there is 0.
Okay. So he is basically normal.
Normal, sir. Yes.
No hypertension, no tachycardia.
No comorbidities.
Yeah, reasonably built, no comorbid, at least on exam. Okay. So will you do
Systemic
what is
exam.
focused neurological examination, FNE?
Yes, sir. It consists of the perianal sensation, the anal tone, the bulbocavernous reflex, the and lower limb reflexes and power, sir, at all joints with the spine examination, sir.
Okay.
So I would like to do that in this patient, sir. First, I would like to do abdominal examination followed by other systems. Then I would like to do a digital rectal examination with focused neurological examinations along with that.
Okay. So cardiovascular, respiratory, abdominal examination is normal.
Yes.
Focused neurological examination is not mentioned,
Yes.
which is desirable, which is strongly recommended in this. Okay. And you know all the components of focused neuro- that is good. Okay. So now you are going to do a digital rectal
Digital
scan.
rectal examinations.
Okay. So
External urethral meatus appears adequate. Penis is normal. Bilateral testis and scrotum normal. Digital rectal examination, tone is normal. Grade 1 prostate, hard in consistency. No nodules. Rectal mucosa is free. Non-tender. Median sulcus obliterated.
okay.
So
Okay.
it's a hard prostate.
So is there any red flag sign here?
Yes, sir. Hard in consistency is thing we have to look for, sir.
So again, I'll ask you the same question. If you find a hard prostate,
Yes, sir.
in what percentage of patients will you find a malignancy?
Around 70 to 80%.
Okay, what are the other causes of hard prostate?
Can be a prostatic infarct, sir, or
Prostatic infarct.
yes, sir, or any prostatic calcification, lymphoma of the prostate, any granulomatous
Prostatic
prostate.
calcification or granulomatria. Prostatic infarct will not be hard. Prostatic infarct would be what happens. What is the pathology of an infarct? What happens to the prostate?
Sir, because of inflammation and glandular enlargement.
Wait, don't confuse. Inflammation is different. Infarct is different.
Yes. Basically, there is a glandular component. There is enlargement and the capillaries and the arterioles get occluded. So there is.
Don't keep on using terms, whatever you know. I mean, the question is very specific. What is an infarct and what is the pathology of a prostatic infarct?
Many a time, Dhruva, the easiest answer is, sir, I'm not sure. That's what the examiner wants at times.
No, I don't want that.
Sir doesn't want, sir wants an answer.
I mean, infarct is something which is taught in the second prof in pathology classes. No, you said infarct, and you have to know it's relatively kind of easy to understand concept. What is an infarct?
There is no blood supply to that focal loss of blood supply to
there
one
is a
particular
focal
region.
area of tissue necrosis, which later on gets converted to fibrosis, and there would be initially some edema, some slight increase in the volume, and later on there would be a contraction of volume. So infarction would generally be associated with not a bulge but a retraction, and the tissue, if it gets calcified, only then it will be hard. Otherwise, infarct would be firm. It won't be hard. Hard is if there is calcification or if there is a tube. Okay. Now, are you happy with this description, or do you want something more?
Sir, they've not mentioned about the. They mentioned rectal mucosa is free. Hard in consistency, they've not mentioned whether the whole gland is hard or whether any particular lobe or any particular part of the lobe is hard. Whole gland is hard.
Surendra, he wants to know whether it is totally a hard prostate or just a nodule which is hard.
Sir, totally hard prostate, sir.
No, no nodules have been mentioned. It's
No nodules.
entire prostate is hard in consistency.
Yes, sir.
Tenderness is not there.
No tenderness.
Okay.
Okay. Have you examined such patients and have you found prostate that is totally hard? And then what is the diagnosis that you have come across in these 3 years? How many patients with totally hard prostate have you seen?
Sir, very few I have seen with totally hard prostate, sir.
Okay,
Most
fine.
commonly, I've seen nodular prostates with a hard nodule, sir.
So if you find a totally hard prostate,
Yes, sir.
what do you think is going on inside the prostate?
It's a diffuse chronic inflammation of the entire gland for a long time.
Chronic inflammation, prostate would be hard. Prostate is completely hard only in 2 situations. If it is completely replaced by a malignancy, or if it is a really calcified prostate having multiple stones or prostatic calcification. And even in prostatic calcifications, you will find some degree of irregularity. If it is uniformly hard prostate, then practically it's a, will you call it a okay malignancy, bad malignancy, good prognosis malignancy? In what category will you put?
No, sir.
Grade 1 prostate.
Whole
Grade
hard
one.
gland, then probably it is a bad malignancy, sir. Chances of extra prostatic extension also will be more, sir. If the entire gland is
The likelihood is that it is
high risk tumors.
it is perhaps almost completely replaced by
Yes,
malignancy.
by malignant. Yes.
And in that situation, likelihood of periprostatic extension into the bladder neck, extension into the sphincter area, etc., seminal vesicles, and there is no. Can you feel normally the seminal vesicles?
No, sir. Normally it's not felt. Only if it's obstructed, it is felt.
And in what other situation can you palpate the seminal vesicles?
Any ejaculatory duct obstructions or any midline prostatic cyst.
Yes. One is ejaculatory duct obstruction. What else?
Then midline cyst, sir. Wolfram duct cyst.
No, that would be in the prostatic area. Seminal vesicles.
Yes, sir. In tuberculosis, sir.
Tuberculosis, yes. Tuberculosis, there may be nodular or irregular seminal vesicles which you may be able to palpate,
Yes.
and you will find very distended seminal vesicles if there is an obstruction. Okay. Good. So I think we are done with the examination part, and now you can go on to the investigations. So Anand will. So Prashant, please take over, and Anand.
Yes, sir.
Anand, Prashant and Anand are now going to do. Before that, Prashant, would you like to know Dhruva to just summarize what he has learned in his history and his clinical examination? What is his likely diagnosis? Any differential diagnosis?
Notes, but I think Dhruva can summarize once for Anand.
You can summarize before Anand takes over.
Yes, 68-year-old male who's a farmer by occupation with mixed lower urinary tract symptoms since 1 month with an IPSS of 21, with a previous history of retention and 1-day history of catheterization, with hard grade 1 hard prostate on examination, with just everything normal, with history of smoking and things.
And you have any differential diagnosis in your mind, or your mind is now fixed on hard malignant prostate?
Sir, CA prostate will be my first diagnosis, sir, after the history and examination.
Okay, fine. Prashant, you're okay with it to proceed for the investigations?
Yeah, so like Dhruva said, CA prostate is his most likely diagnosis. And if he can extend, he is also going to think that it might be a locally advanced prostate cancer because it feels it is completely hard, right?
And so Prashant, are we surprised in this case, being an entirely hard prostate? In spite of that, we are not able to find an extracapsular extension clinically in this patient. I think they have not mentioned about any extracapsular extension in this patient.
Extracapsular extension, yes, clinically they are not felt. Like Dr. Amlesh Sir also told, it is very rare to find these prostates which are completely hard in its entirety. Generally, most of the CA prostate, most of the localized CA prostates would have focal nodularity or focal areas of induration and hardness rather than being completely hard all over, right?
And Prashant, one other question which the candidates will always like to know from us is why don't we grade a prostate when it comes to malignancy? We always grade the prostates in BPH, but it has been a classical teaching for most of us, don't grade the prostate when it comes to malignancy.
So grading, how is it going to be of any use in CA prostate? So we are going to either whatever beats management. So resection is not going to be management for grading. So there is no point in grading. And again, grading is going to be fallacious because the size and the growth pattern is not going to mimic how it is for a benign non-malignant prostate where it will be uniform growth. It might be a growth only in the posterior. So you would not be able to actually what you call very reliably tell that this grade 1, grade 2, grade 3. Whenever we say grading, we have got a connotation that that corresponds to a particular size. That may not be true in a CA prostate or a malignancy where a particular grade may have only a focal growth on that side and that may not correspond to the entire gland.
Perfect, Prashant. Candidates, you got the point. There are nearly 150 students who are currently listening to us. There's extremely important points because in an exam, when you say I am grading this prostate grade 2 or grade 3, that means you are saying you're looking for a benign prostatic enlargement, not for a malignant prostate. You usually do not grade the prostate in CA prostate because it's not going to help you in your management. You're only worried whether it's confined to the prostate or it's beyond the prostate. Second thing, as Dr. Prashant is making, it is never an uniform enlargement in a CA prostate. It is usually localized to one particular lobe. It may be enlarged, it may not be enlarged on the other side. So grading is of almost immaterial for us in a CA prostate. Yeah, Anand, you can go ahead with Dr. Prashant. Yes.
So
Yes,
Anand, you have heard the history, you have heard the differential. Now imagine yourself sitting in OPD and
Yes.
trying to reach the diagnosis.
Yes,
So
sir.
what would you do for it? What do you do?
So, with the history and the clinical examination we have, the most likely diagnosis because of the hard prostate and all the history we have had is most likely it is CA prostate. So, first of all, I would like to go with the sir USG to rule out other causes of obstruction, bladder outlet obstruction, to see if there is any stone in the bladder or to see any changes in the bladder wall thickness with upper tract changes as well, kidneys and how this is CMD and PCS, if there is any dilatation upper tract are normal or not. I would like to go with that. And then
So
with
if I
the
ask you why an USG, so the answer would be that USG is an extension of my clinical. I have it in my OPD, right? I think that is the way
yes,
to answer. Yes, that
yes,
I can do it immediately and yeah, okay,
yes.
right.
And I would also like to see, sir, any PVR if there is present, postward residual urine and size of the prostate as well, sir. Those all that information will help me to narrow down my diagnosis and confirm my diagnosis. And then
In-
I will go with the blood workup, sir.
Other than local findings, can USG tell you something else? When you're doing an ultrasound, you would also like to get an ultrasound abdomen and look for the viscera because prostate cancer is known to have visceral spread. You may not get the skeletal mets, but if there are visceral mets, you would. So you would complete that. Yes, I'm going to do local as well as I'm going to do this. Hello.
Yes, sir. You are audible, sir. Yes, sir.
Yeah, I think temporarily we have lost Prashant. I don't know why. Prashant should be joining us shortly. Amlesh sir, can you kindly take over at this stage, sir, till before Dr. Prashant joins us? Yeah, my request Dr. Amlesh sir to kindly take over. Prashant is has some technical glitch, I believe. Anand, where are we exactly?
So we were discussing about this findings on the ultrasound as an extension of the physical examination.
So you prefer to do an ultrasound as an extension of physical examination in this
Yes.
particular case.
Yes, sir.
You don't want to go with the routine investigations?
Sir, routine investigations first, getting a
Any
ultrasound.
specific reason why you are very specific? Because you had made a clinical diagnosis of CA prostate in this case. If you're going for an ultrasound, what are the things you really want to see in an ultrasound in this patient?
Sir, ultrasound will give me information about the size of the prostate and
Yeah, meanwhile, just Anand, 1 second. Arushi, can you just try to get Dr. Prashant Nayak back online?
Sure, sir, sure.
Yeah, Prashant, sir. Yeah. Prashant is back on the virtual. Prashant, I was just asking him what was
I
he
just
expecting when he was going for an ultrasound in CA prostate. As he asked for a CA. Yes, Anand, go live.
yes.
Please go ahead.
Yeah. So we were discussing about that CA prostate. Ultrasound will also give us a clue about the local extension of the tumor as well beyond the prostatic capsule, and involvement of even rectum it can give us idea about the involvement of the rectum in the
Your routine
area.
abdominal ultrasound gives you an information about the rectal involvement.
Sir, if we are doing ultrasound whole abdomen with the KUB, sir, it will give us a little bit about viscera as well if the
You're
viscera is
basically
involved.
looking at the homogeneity of the prostate, whether it is infiltrating your bladder or not. That will be seen as a bladder wall thickening. If there
Yes,
is any hydroerythronephrosis, that also gives you an idea that probably there is a bladder wall infiltration in this patient. And
yes,
you're
sir.
looking for residual urine as well as dilatation. I think that is the most probable answer we want from you. Yeah, Prashant, please take over.
Yeah. So what are the features which will tell you that it's a locally advanced disease? I think that is the question. So sir was asking. So what are the features on an ultrasound which will tell you that this is a locally advanced? This is probably a locally advanced CA prostate.
Sir, all the features like the bladder wall will be involved with maybe there are infiltration into the bladder which will lead to upper tract changes as well, dilatation of PCS.
Yes.
That will give us about local extension.
Seminal vesicle. If you can
Yes.
visualize a dilated seminal vesicle, that also probably indicate that there is some obstruction there, and that also could be due to a locally advanced CA prostate.
CA prostate.
Right. So ultrasound, this much you can get. Then what next?
So next I will go with investigations, sir, blood investigation. Like we'll get a PSA done, serum PSA,
Okay.
and
So
all the
yes, PSA done.
yes.
So do we have the PSA report here? So do you have the PSA report? Okay, 54. Right.
So PSA is 54, sir. It is very high, sir.
Okay. So what next?
So now we know that it is a PSA is high. So and prostate is hard. So most likely it is diagnosis. The diagnosis would be CA prostate. But sir, we would like to do another value of PSA as well because we have a single value. So I would like to get another one more value of PSA done after 4 weeks after giving maybe antibiotics. If the patient is after getting urine RM and urine CS done, if the patient is having any component of UTI, I will give antibiotics.
So what is this idea behind repeating a PSA? Is it because you think that this was UTI or prostatitis which has led to raise, or is it because you do not believe the lab you want to repeat? So what is the reason you want to repeat it?
Sir, just sir, one more value would help us confirm that PSA is raised. But sir, we are not in the doubtful range, sir. It is more likely would be CA prostate.
No, the idea behind me asking this question is if you want one more value, is
Yes,
it going to be tomorrow or is it going to be 1 month apart or 2 weeks apart or 3
Sir,
weeks?
1 month apart, sir.
Okay.
We
So
get
1
it
month
in at
apart?
least 1 month apart in our institute, sir.
Okay. Right.
At this point of time, I would like to ask one doubt to both our examiners, because when we have a clinically strong diagnosis of a malignancy and the PSA values are 54, we always have a dilemma whether to repeat or not. Because as Dr. Prashant and our Dr. Amlesh Seth has said, a prostatic infarction could also lead to a retention. We have seen values even 250 or 300 PSAs also in prostatic infarction. These high PSA values have to be repeated. Your textbook says 3 months, but practically 4 weeks. But when you have a strong clinical diagnosis of malignancy with a hard prostate, we are also of the fear whether if you wait for 4 weeks, are we going to lose something? If the patient asks, sir, why you waited for 4 weeks? Now my diagnosis, you are diagnosed after 4 weeks. These questions will usually arise in our practice. Prashant, in this case, when you have a clinically hard prostate, should you wait for further investigations, like repeating a PSA after 4 weeks, or we'd like to proceed straight away with the next set of investigations?
So I would continue with my line of investigations, but definitely I will get another PSA down the line. The whole idea of this waiting for some time is not for antibiotics. If this is say chronic prostatitis, or if it in fact, or if it had been if it had been an acute rise, it will need this much time for it to come down. So if it comes down after 4 weeks, then I will have a second thought that okay, this might be something else. But in the era of this multiparametric MRI, when that is available to us, I see no reason why not. So even if it is 54, like you very rightly said, I do not expect it to come down to less than 3 or 4. And if it is not going to come down less than 3 or not, anyway, I'm going to do an MP-MRI. So you are very right in saying that such a large PSA, we should probably continue our line of investigations, thinking that this is probably due to malignancy of prostate. Right.
Please.
So Anant, please continue.
Yes,
So
sir.
PSA is high. What next?
Sir, PSA is high, sir. Prostate is hard and PSA is high, so we have a very high probability of CA prostate. So we can, sir, we can directly go to getting biopsy done to confirm our diagnosis.
So what kind of biopsy would you get?
Sir, we can get both transperineal and transrectal. The first choice would be, sir, according to our text, it is transperineal, but here in our institute, we are mostly doing transrectal biopsies, sir.
So would you not like to get an MRI? So just now I mentioned
Sir,
about parametric
yeah.
MRI. So would you not like to get a multiparametric?
Sir, getting a, sir, we, as the prostate is hard and it is highly likely that it is CA prostate, sir. So I'll get first to confirm my diagnosis and then I'll go to staging, sir. I'm not in the doubtful range, sir. It is, I'm not in doubt that.
So there is a small issue here.
Yes,
If
sir.
you look at what was found in clinical examination, it was a clinically hard all over prostate without any nodularity. So there is a high chance that there could be coexisting chronic prostatitis, which could also lead to this hardness of the
Yes.
prostate. If you find a very nodular prostate all over with obvious signs of metastasis, and only that is the only indication where I'll forego an MP-MRI. Otherwise, I would definitely get an MP-MRI because I do not want to miss. If I do a biopsy, I don't want to miss. I don't want to take a chance that I miss a viable tumor and then I push the patient back on his treatment. So that is the whole idea that I would get an MP-MRI. If you go to the guidelines, MP-MRI is probably recommended before all prostate biopsies, right? But only thing, even you are working in the SMS here also, we have a huge patient load and all that. We only forego MP-MRI in a very nodular prostate with a very high PSA when we're very sure that we're going to hit cancer. So only then we'll forego. Yeah.
Yes.
So if you do an MP-MRI, what are the advantages of an MP-MRI?
Sir, MP-MRI will give us the location of the lesions and it can also give us the local extension of the tumor as well. It is very good for local T staging, sir.
Okay, so now my next question is, when I say advantages vis-a-vis your prostate biopsy, how is an MP-MRI going to help your prostate biopsy?
Sir, MP-MRI will be able to grade those lesions according to the Peyraud's scale, and we'll know that what the probability of that lesion being malignant is, and then we can go for biopsy, sir, and we can also go for targeted biopsies as well, sir.
Exactly. So the answer is targeted biopsy. Now my next question is there evidence to suggest that targeted biopsy is equivalent to systematic biopsy plus targeted biopsy? Is targeted biopsy equivalent to systematic biopsy? If you do targeted biopsy, can we forego systematic biopsy? Anant, you got the question?
Yes, sir, I understood, sir. So systematic biopsy would give us the complete sampling of the prostate, and it will tell us more of the tumor burden.
Okay.
targeted biopsy would definitely give us the lesion and the pathology and the diagnosis of it, but still it will not give us the burden if the prostate is completely involved or not.
So if you go and read evidence now, targeted biopsy is as good as systematic biopsy in terms of not missing the malignancy. You are not going to miss the malignancy. You are not going to miss the clinically significant malignancy. So that is where MPMRI comes in, a good reading of an MPMRI. This is again a caveat because most of the radiologists are not trained to give a good reading. If you have a good reading and they are able to tell you that this is a Pirates 4 lesion, this is a Pirates 5 lesion, and you target this Pirates 4 and Pirates 5 lesion, you are going to not miss this clinically significant. You are going to get the accurate grading, and you are also going to avoid doing a systematic biopsy. So that is what is coming up now. So in my institute also, we continue to practice targeted plus systematic biopsy because we do a cognitive fusion. We do not have the fusion machine with us. So
Yes.
I do not realize if you have a good fusion apparatus, then you can probably rely on targeted biopsy alone. In the absence of that, you would like to do both targeted as well as a systematic biopsy. So I agree with you there.
Yes.
Right. So do you have the biopsy reports, Purinder?
Or Surinder, I think, Prashant, I think they have done an MRI before the biopsy. Can we see
So,
possible?
like I said, an MRI
Yes.
always, yes.
Yes.
So do you have particular films which is relevant, Surinder? I think it's difficult for Anand to read. Anand, do you make any head or tail out of this?
So I would like to see prostate.
Is multiparametric necessary or what can substitute multiparametric?
Sir, there is also biparametric MRI also is done.
Which is missing? So what is missing in your between biparametric and multiparametric? Bi is only 2 and multi is 3 or 4?
3, sir.
3. So what is missing?
3. DWI, ADC, and we do.
What you don't give?
So we don't give gadolinium, sir.
Yeah, so we don't do the DC or the dynamic contrast enhanced.
Yes, sir. DC we don't do. Yes, sir. Yes.
DC is not.
Yes, sir.
So
When do you
what
do?
is the role of
Can we
DC?
ask him when do we do?
Yeah, so what is the role of DC exactly? So what is the role? When do you give this DC?
DC, sir, helps us to differentiate between, sir, Pirates 3 lesion when T2 image when we do T2 weighted MRI, sir, it gives Pirates 3 and we have a confusion if it's
3 and 4.
yeah, if it is 3 or 4, sir. If there is the lesion, sir, it is hyper intense on T2. The cancer is hyper intense on T2, and if we have doubt it is Pirates 3 or 4, then we do DC.
And
To
if
see
it shows good enhancement, then
if sir, on DC, if the enhancement is more, sir, it means it is Pirates 4.
yes. And what is the difference between DC 4 and 5? Or sorry, what is the difference between Pirates 4 and 5?
Sir, Pirates 4 and 5 is cancer is likely and very likely. So
No,
4,
what is the image characteristic difference between 4 and 5?
sir, in T2 weighted image.
Yeah. So 4 and 5 depends on only size of the image.
Size 1.5 centimeter होता है. Yes, it is
If it is less
1.5
than
centimeter.
1.5 it is 4, more than 1.5 it becomes 5.
It becomes, yes, sir. It becomes Pirates 5.
Yeah. Surinder, what is the report?
I will show.
Yeah, MPMRI report.
Prostate measures 6.3 cross 6.4 cross 5.5 centimeter and a large diffuse T2 hypointense lesion showing diffuse restriction with a significant low ADC value and not involving almost entire prostate. Extragranular invasion noted predominantly on the left posterior. Posteriorly, the lesion is seen infiltration in the anterior wall of the rectum with the soft tissue thickening being adherent with the left iliococcygeus muscle extending with inferiorly levator and a insertion site.
Okay. And invading posterior wall of urethra.
Posterior wall of the urethra.
Anything else? Have they commented about lymph nodes?
No, sir, they didn't comment about the lymph nodes.
Anything else you want to ask Anand in MRI?
Anant a little confused because he thought it is a localized CA prostate case today. You got iliac oxygen involvement on all these infiltrations.
So we had a clue, right? He told that it's a completely hard all over. So this is what it appears.
Prashant, the bigger problem with our candidates now is when they go for specific investigations like they talk about an ultrasound. An ultrasound gives you an idea about CA prostate. Then they move towards a trust biopsy, MRI. They have left the routine investigations.
Yeah.
So nowadays, yeah.
Actually, I am also the culprit because I asked Anand that we are going for the diagnosis. So that is why probably we are gone into that.
So it is great on part of an examiner to say, I also took you to a different direction. You are a super examiner, Prashant. We want you as examiners now. Good.
Yeah, and so we also had a doubt about the hip joints. So this MRI gives you an excellent opportunity, as Dhruv was saying, that there could be metastasis. So whether there is a metastatic lesion in the hip joints, you could clarify in this MRI picture, right?
Yes, sir.
Okay. So what do you think based on this MRI report? So what is the focal stage of the tumor?
Sir, the T2 hypointense tumor, sir. So ADC values are also low, sir.
Extraglandular invasion is there, infiltrating into the left iliococcygeus muscle.
Yes. Yes. It is
And
a T
rectum.
stage would be sir T4 because
Yes.
yes, sir.
Yes. Okay. Next,
Yes,
what
sir.
do you want to do?
We have the local staging now, sir. I would like to
We haven't done biopsy now. After this, we're going to do the biopsy.
yes, sir. We would need trust biopsy report as well, sir.
Okay. So let us see. Anand has done a transrectal ultrasound guided biopsy. So what's the report of that? Yes.
1 course.
How many courses would you like to take?
Sir, 12 course, sir.
Okay.
Total 12 course, yes, sir.
At least 12 courses. Yeah.
At least, yes.
So this is the report. So give me the
Yes.
diagnosis now.
So it is a, sir, locally advanced CA prostate, sir, with a Gleason score of it is, sir, 8, sir. It will come into ISUP grade
Grade group.
4, sir. Grade group 4. ISUP grade group 8 because it is 4 plus 4, sir. It will come into 8.
What next?
So next
Investigations. Yes. Come on, we are yet to reach the management. That's why I am just.
Sir, I'll go for, sir. First, I'll go for risk stratification, and then I'll stage the patient to see according to in what risk group the patient lies. If it is in high risk group, it seems like the patient is high risk group, sir, because it is ISUP 4. So I'll go for staging also, sir. I will get.
I would like to stage the patient first.
Yes, sir.
Yeah. So what is the stage? So how do you stage this patient?
Sir, so for staging investigation, we can go for, sir, we can go for PSMA PET, or we can go for CT abdomen, pelvis, or bone
for
scan.
anything. What would you go for?
Sir, I'll go for PSMA PET, sir.
You would go for a PSMA PET scan.
Yes.
Why? What is the reasoning behind that?
Sir, PSMA PET will give us all the metastatic lesions, sir, and it will give us it will give us all the staging, sir.
Okay. So
As
do
with MRI, we have the local staging, so we want to see the metastatic lesions.
So do you have the PSMA report? So we have a bone scan. So what
Okay.
are your thoughts about bone scan versus PSMA PET scan?
Sir, bone scan is more widely done, sir, rather than PSMA PET. Bone scan
Actually,
will
I would
also.
like to correct you there. India is one of the countries with the highest penetration of PSMA PET scan. In fact, we do PSMA PET scan left, right, and center availability is in every nook and corner of the country. So we have a lot of PSMA PET scan. Yeah. Okay, please continue.
So bone scan will also give us all the metastatic bone lesions because, sir, most commonly the CA prostate metastasizes to the bones. So bone scan would
So
be.
let me put the question. So what is the advantage of PSMA PET scan over a radionuclide bone scan in localized CA prostate or locally advanced, localized or locally advanced CA? Clinically localized and locally advanced, you are doing a PSMA PET versus a radionuclide bone scan.
Sir, it will PSMA PET will also give us a local staging as well, sir.
No, I mean to say your management would change in what percentage of patients over a radionuclide bone scan. You have, so what I mean to say is in radionuclide bone scan you are picking up a localized disease.
Yes.
But in how many patients of this would PSMA find a metastatic disease? So that is how your management would change. You got the question?
Yes, sir, I got the question, sir.
What percentage of patients would PSMA PET upgrade to metastasis in such a scenario?
I'm not aware of that, sir.
Okay.
Yes.
So be aware with somewhere around 25 to 27% of patients would at least undergo a up migration to a metastatic disease. So that is the advantage of PSMA PET scan. So this has been borne by multiple trials on PSMA, right?
Yes.
So what did the bone scan say?
Findings are compatible with the non-specific polyarthritis along with significant residue of urine in the bladder. Study is negative for metastatic bone disease.
Okay. Is it enough if you do a radionuclide bone scan?
Radionuclide bones for metastatic workup, sir, bone scan would be enough, sir, because most probably.
So if you do bone scan, would you like to combine it with some other investigation?
Yeah, sir, we should do a CT abdomen and pelvis as well to see if their visceral mets are there or not.
So bone scan is generally combined with the CCT abdomen and pelvis.
Yes, sir, it is combined, sir. Yes, mostly.
Prashant, at this particular stage, I think Anant at one point of time said that CA prostate most commonly metastasizes to the bone. So would you like to ask him at this stage why it goes to the bone specific?
Yeah.
Because that's a part of an exam question, yes.
Yes. Please answer.
Sir, it is because of the,
this is
sir,
coming.
it is because of the venous plexus or Bateson plexus, which allows the cancer cells to migrate up to the lumbar vertebra and cause metastasis.
What is Bateson's plexus?
Sir, it's Bateson plexus, sir, vertebral plexus of veins,
Okay.
which.
So why does CA prostate go there?
Yeah, all malignancies can go. Why CA prostate alone goes
Why
there?
CA prostate alone goes to Bateson's plexus and then to axial skeleton?
So it is because of the flow of the valves are not present in.
Because of the periprostatic venous plexus is in continuity with this Bateson's plexus.
Yes.
Okay, so there is a communication. Am I right, sir?
Yeah, perfect. This is communication. At the same time, CA prostate in one condition where patient strains to void. That is again one reason why it reflexes back. So these are the very classical exam questions for you. And again, Prashant's exam question on PSMA PET. Now, if you had a PSMA PET in this case, if it showed an activity in the bones, probably you are a little more sure that it is a prostatic malignancy. Now, osteoarthritis or prostatic malignancy, you are now in a confusion when you do a simple MDP bone scan. But even PSMAs can be positive in osteomyelitis. That's also possible. But the upgrading of around 25 to 37% is definitely acceptable when you do a PSMA PET.
Taking off from what Saraj asked, sometimes in PSMA PET scan you get confused. You have a very faint uptake in the bone. And when the CT component of the PSMA PET does not show any architectural changes, what would you do then? It shows a faint PSMA uptake,
yes,
and CT component shows bone looks normal. So would you classify it as metastasis Would you classify it as some inflammatory changes?
Some
Or
inflammatory or metabolic bone, some
so can
lesion.
you do something? What would you do
Biopsy.
to
We can get a
resolve?
biopsy done of that lesion,
Yes,
sir.
biopsy you can do, but biopsy becomes invasive. Something non-invasive. This is a recommendation. If there is a doubt, you do this. You do an MRI. You do an MRI of the bone. So MRI of the bone would be able to differentiate in this difficult scenario where PSMA ability is low ability without any structural changes in the bone, right?
Okay, sir.
Okay. So yeah. So what next? Now that we know that it looks like a locally advanced non-metastatic disease.
Yes, sir. Now,
CT scan. What are the reports of the CT scan, Surinder? Just to rush you.
Yes, Surendra, I think you read the report.
Evidence of irregular heterogeneous enhancing soft tissue density lesion noted in the prostate of 8 cross 6 cross 6 centimeter. And there is a loss of fat plane between the lesion and the bladder and the anorectum. And impression features suggestive of prostatic cancer with the invasion into the bladder and the anorectum and the right hydrocele and a suggestive PSA correlation.
Surendra, the examiners want to know the rest of the abdomen. Rest of the
So
abdomen is normal.
was normal.
Rest of the abdomen is normal.
Normal. Sir.
Okay, so again, we have a locally advanced non-metastatic CA prostate, adenocarcinoma prostate with Gleason grade group 4 with a PSA 54. Yeah.
Yeah. Prashant, now at this stage, can we take Dr. Amlesh sir also
Yes,
in? Now
yes,
we are going
yes,
towards
we can
management.
go to the treatment.
Rishi, can you call Amlesh sir and can you take Amlesh sir in?
Okay, sir.
Yeah. Prashant, you can continue. You can continue.
Yeah. So what are the routine investigations? So sir was asking now, we would
Yeah,
need to do other investigations. So what are the other investigations?
The other candidate can also join in.
sir, we
Other
will
candidate.
do all the urine routine microscopic examination and RFTs as well, sir.
Okay.
Because we all, KFT and serum electrolytes we would like to see, sir, before proceeding with our radiological examination.
LFT too, sir. LFT.
Anything
Liver function test as well.
LFT?
Liver function tests and calcium also, sir.
Okay.
Serum, yes, sir.
Then you will get fitness. Sorry. Okay. So depending on what you want to do. So what are your thoughts, Anant?
Yes, sir.
What would you like to do in this patient who has got a locally advanced T4 disease N0 until now? He is clinically and imaging wise T4 N0, M0, N0, M0. Yeah.
Sir, in this particular case, sir, I would like to go for, sir, treatment as a treatment modality doing radiotherapy for this patient, sir, because it is a locally advanced CA prostate. So radiotherapy would be a better option for this patient, sir.
So again, your answer is incomplete. Dhruv, can you complete the answer?
Yes, sir. Sir, I would like to first discuss with the patient, give him options, and I would like to give him an opportunity to make shared decision making. I would give him options of it is a locally advanced. He has. I would give him option of radical prostatectomy with pelvic lymph node dissection, extended pelvic lymph node dissection, and then I would also give him an option of radiotherapy. But I would also tell him that. Removal of primary tumor is better. So,
for exam purpose, for a T4 disease, please do not mention RP as a choice because that is not an option in an exam setting. At least upfront RP without neoadjuvant, there is no role at all. And for exam, better not to get into that issue at all. Sir Amlesh, sir, till now the investigations have revealed it's a T4 N0 M0 disease. So a radionuclide scan has been done, CT scan and an MRI scan has been done. So which has not shown any distant metastasis. It's a T4 grade group 4 N0 M0 adenocarcinoma prostate without any metastasis. So I was just asking them what they want to do. Yes. So Anand said he wants to do radical RT. And Dhruv says he wants to give option between RP and RT, but I still feel answer is incomplete. So yes, sir, please go.
Okay, supposing the patient accepts radical prostatectomy, What are the complications that you will expect in this case?
Sir, high chances of surgical margins being positive, sir, in this.
What margins will be positive?
So the posterior margin, sir, and the urethral, when we dissect near the urethra, sir.
Urethra is invaded, sphincter
Yes.
will definitely be invaded,
Yes.
seminal vesicles are invaded, bladder neck is invaded. So everything will be positive. Every margin will be positive and patient will be totally incontinent. And then there will be residual disease in the prostatic bed. Patient will be totally incontinent, there will be residual disease, and then for residual disease, then will you advise radiotherapy?
Yes, sir. If margins are positive, then radiotherapy.
This is Gleason 8 disease.
Yes.
Margin positive नहीं होगा, इसमें residual disease आएगी.
Yes.
It would be a, what is the R1 resection? What is an R2 resection?
R1 is positive microscopic surgical margin, sir.
Yes, and what is R2?
R2 is gross residual disease.
This patient, if it's subject to radical prostatectomy, will have gross residual disease.
Yes.
Because you will not be able, you won't go till the ureteric orifices, you won't go till the bulbar urethra, and short of that, everything is positive.
Yes.
Periprostatic margin will definitely be positive. And perirectal is also positive.
Yes.
There will be a high chance of rectal injury also. So there is no question of radical prostatectomy as an option to be given to this patient. No. Please don't give that option. Okay, so what are the options remaining?
Radiotherapy, sir.
ADT.
Radiotherapy, is radiotherapy
And,
given alone?
No, sir. ADT with RT, sir. We'll early ADT, give him an option of early ADT followed by RT, sir, IGRT.
So what is the usual protocol? For how long does the patient receive ADT and then patient goes for radiotherapy? What is it? How does it practically work?
Yes, sir. It's a high risk disease, so ADT is
No, if you refer this patient to the radiotherapist, what will
Yes.
the radiotherapist do? What will be the advice given to the patient? When to begin hormonal therapy and when should the patient undergo a radiotherapy? Do you begin with radiotherapy first or do you begin with hormonal therapy first?
begin with hormone therapy first, sir.
So for how long is the hormonal therapy continued? Before
So
it
it's started and concurrent radiotherapy is given, and even post radiotherapy it has to be continued for
No, initially there is a hormonal therapy which is given for a period of about 3 months or so. What is the idea of giving hormonal therapy for 3 months or so?
reduces the burden of the disease, sir. It makes it amenable for radiation. The field of radiation can focus more, and the chances of radiation toxicity to the other organs can reduce, sir, with the ADT.
Yes, and it also shrinks the prostate. So
Yes.
it can be more. What is the dose of radiotherapy that is required?
Sir, again, if they're giving only IGRT, sir, if they're giving only IGRT, it's given at 80 gray, sir. If it's combined with brachytherapy, 45 gray of IGRT and 60% of dose of brachytherapy is given, sir.
Okay, when you say 80 gray of IGRT, is it dose-wise a low dose, a moderate dose, a high dose? What is it?
Sir, 80 gray will fall under high dose, sir. Less than 66 gray is.
What are the usual doses of radiotherapy that you have come across for other malignancies? Okay, let us talk about testicular cancer. What is the dose of radiotherapy given for stage 1 seminoma? If you have to.
20 grays.
Yes, 20 gray, at the most 25. So this is 80 gray. 80 gray is 4 times the dose.
Any
And
reason why?
such a high dose cannot be given unless it is an image guided. And that is why traditionally radiotherapy was not effective in CA prostate. Because if you give whole field, then the amount of radiation that will go to the rectum and bladder would damage the rectum and bladder to a large extent. And the dose given to the prostate would not be adequate. So the control of prostatic malignancy with conventional radiotherapy was very poor. So that is why prostate was considered to be radio-resistant bladder tumor. Nowadays, with image guidance and okay. Now, this is a 8 by 6 by 6 centimeter lesion. How much radiotherapy do you think he will need? 80 with this large a disease. Okay, tell me one thing. If there are mediastinal, if there are retroperitoneal nodes that are positive, what stage is that?
It's M1A, sir.
M1,
A.
2.
M1A,
Lymph
sir.
node metastasis is considered a metastatic disease in CA prostate.
Yes.
Okay. Do we know that this patient has lymph node metastasis or not?
Yes, sir. The
Yes, sir.
CT
CT abdomen has
does
been
not
done.
show any metastasis.
CT abdomen has been done, but it's not a PSMA PET CT.
Yes.
Yes, sir. PSMA is not.
Yeah. Actually, PSMA is strongly desirable in this patient.
Yes, sir.
Because where this patient has significant metastatic load or not, this patient is likely to have a significant metastatic load. Because his PSA is 45 and he has locally advanced disease. Okay, tell me what is the significance of perineural invasion on the biopsy?
Yes, sir. It indicates high chance of extraprostatic extension and metastasis, sir, if perineural invasion is seen.
What about
And
lymphatic?
high chances of margins being positive after RP, sir. It is also one of the indicators, sir.
Perineural invasion was earlier considered to be an indicator of poor prognosis. But if you find perineural invasion on biopsy, that does not necessarily indicate a poor prognosis. Because within the prostate also there are some nerves, and around those nerves also you can find malignant tissue. And therefore perineural invasion on the prostatic biopsy is not necessarily a poor prognostic indicator. But there are a number of, this is not only locally advanced, this is locally significantly advanced disease. With the rectum being involved and the urethra being involved and the bladder neck being involved, this is almost equivalent to a metastatic disease in terms of prognosis. In terms of prognosis, this would be just marginally better than metastatic.
So, Anand,
Yes, sir.
sir is told to give radical RT. Does it only include prostate or would you give to the pelvis also? Pelvis, retroperitoneum, how far? So what is the field of this radical RT?
Sir, this is a high risk disease, so we will also give pelvic RT, sir.
So how long are you going to give ADT? We mentioned ADT.
ADT is given in these high risk cases are given for 2 to 3 years, sir.
Okay. Have you heard of the term systemic intensification? So what is systemic intensification? Does it apply here? Is it only RT plus ADT or RT plus ADT plus something else? And
Sir,
is there evidence to
we give
support?
RT plus ADT plus abiraterone as well, sir, in these cases.
So
Yes.
that is called systemic intensification. Probably the full RT would be a radical RT, including the pelvis and ADT for 2 to 3 years, as you rightly said, with systemic intensification, with this abiraterone.
Yes.
Right. So that would be the full thing of this.
Prashant, I would like to ask one question to both yourself and Dr. Amlesh sir. Generally, for these localized tumors or locally advanced tumors, an ADT of 2 years, and for the metastatic tumors, probably a lifelong ADT. Now, this being a significantly advanced local tumor infiltrating almost the coccygeus muscle, would you require an ADT lifelong in this patient?
So that is what Amlesh sir very rightly said, that this is almost bordering on metastatic disease. So this probably would need a long-term ADT, or probably we would see this patient develop some kind of like metachronous this metastasis. Or as sir said, if you do a PSMA PET anytime, you'll probably see that this patient is already a metastatic disease.
So, Anant, definitely Amlesh sir would like to ask you, how would you follow up this patient now having started ADT and RT?
Sir, then we'll follow the patient after giving treatment, sir. We will get PSA done, and we'll PSA to be done at regular intervals and to see if there is any biochemical recurrence. And then we can go from there. If there is any biochemical recurrence, we can get further workup and investigations done. And then further treatment with respect to the if there is any biochemical recurrence or not, sir.
So before we go there, can I ask one question that is now relevant? What is the role of hypofractionation? So we mentioned about 78 to 80 grays. Does hypofractionation, it is now become a fancy word everywhere. What is its role in localized CA prostate, locally advanced CA prostate?
Sir, in hyperfractionation, we give the RT in a short interval of time and with decreased number of fractions. If we are giving 78 in 28 weeks, we will give 16 20 weeks. In 4 weeks, in
So
20
we
fractions.
increase the dose and decrease the duration.
Yes, sir. Dose
What
and duration.
is SPRT? What is stereotactic body radiotherapy?
So stereotactic body, it is a kind of a conformational radiation therapy, sir.
It is an extreme hypofractionation. So some early data has come regarding CA prostate, which show equivalence, but at the cost of slightly more adverse reactions compared to a regular fractionation, this RT. Okay, sir was asking about follow-up. Please continue.
Sir, for follow-up we will see if sir biochemical recurrence will get PSA done at regular intervals, sir. And we'll see if there is any biochemical recurrence, and then we will go for further workup, sir, if there is any recurrence.
What is the definition of biochemical recurrence in radiotherapy, and what is the definition of biochemical recurrence after radical prostatectomy?
Sir, after getting radiotherapy, after doing radiotherapy, biochemical recurrence is defined by sir nadir value plus 2. That is biochemical recurrence in RT. And when we do sir radical prostatectomy, then biochemical recurrence is defined by sir two values are there, sir, more than 0.2. Two values are to be done at 6 months apart, sir.
No,
And they
no,
have
6
to,
months. No, not 6 months.
so two values we need, sir, which should be more than 0.2 nanogram per ml.
So what is called undetectable PSA? After RP, suppose you do and you find, you say that patient had undetectable PSA. So what is undetectable PSA?
The undetectable, sir, undetectable PSA is generally not.
Or rather, when would you say that PSA is normal, or you're not bothered about? After RP, what level of PSA do you expect? Proof?
Sir, less than 0.01, sir.
Less than 0.01. Yeah, less than 0.1. Yeah. Right.
0.1, yes.
0.1.
Yeah.
So the half-life of PSA, the roof starts falling because PSA half-life is only 3.2 days. By around 4 weeks' time, it should actually hit zero. But we have different levels of investigation, different labs have different settings. So there is always a confusion what should be the final value. So many people have agreed 0.2. So if anyway is less than 0.2, we'll take it as it's fairly under control. Now, Prashant, do you agree with the management protocol in this patient? So I think Dhruv and Anant prefer in this patient an ADT followed by RT, probably a lifelong ADT with an addition of abiraterone as necessary for this case and follow-up of this patient. So Prashant and Amlesh sir, you both agree with the management protocol in this patient, sir?
Yes, yes. He
Yes.
will need a
Yes.
very aggressive management, and mainstay would actually be to begin with hormonal therapy and upfront addition of abiraterone, and then one can see how good is the response. If the response is very good, only then he will be a candidate for radiotherapy.
Right.
Otherwise, he'll have a lot of side effects of radiotherapy without benefiting very much.
Amlesh sir, now we are going into the questions. Since the discussion on this case is complete, we'll take a few questions for the next 15 minutes. One of the questions is the role of neoadjuvant therapy, hormonal therapy in CA prostate. Because for the postgraduates, the textbook describes that there is not much of proven role of neoadjuvant, but there are a lot of studies, I think predominantly coming from Chennai, where they're doing a lot of neoadjuvant ADT and following it up with RP. Is it still an acceptable protocol for the postgraduates still in the exam, or let them defer it for the time beings?
No, this is not the standard of care, and it is under study. And if the results prove to be good, then only it will come in the guidelines. Earlier, neoadjuvant hormonal therapy has been tried, but not with very good results because the surgery has become more difficult after neoadjuvant, and the long-term survival data has not shown any benefit. So it is not in the standard of care, it is under study.
Sorry. Prashant, the other question that is coming up from PGs is this grading of prostate. Anyway, that applies more to BPH than for CA prostate. There's so many grading of prostate. One person says finger is reaching comfortably up. The other person says two finger breadths away from the midline. All these gradings important. What gradings to follow in the exam? This 2 or 3 times this question has been repeated by our candidates in my group.
So
The
I-
attendees group are actually giving us questions. At the moment, there are 167 attendees inside now who are giving questions to us. Yeah.
Right. So, we rely less and less on the size estimation due to because of our ERE. So, what I keep it very simple for my residents: grade 1, 2, 3, whether you're able to reach above the prostate or not. So, based on that, whether you're able to reach easily, not able to reach above easily with difficulty, or not able to reach. So, that's a very simple way of classifying. More than that, we do not need for BPH. What benefit would you have if we estimate the size and know that it is 40 grams, 50 grams? We know that these are error prone and this will not account for the intravesical protrusion of the prostate. So ultimately the size that we get and what size we find inside when we're intervening, it is not going to be the same. We are going to be dependent on our imaging. So we should keep this simple as far as the estimation of size of the prostate is concerned with DRE. Yeah.
And it also depends on the length of our fingers also.
Exactly.
Absolutely.
So do not give a lot of credence. Yes, we know that it is just 1, 2, 3, just to have an idea between us. So that
Correct, correct.
But for the exam, this is one way. Another method which is actually used by a lot of, it's not given in Campbell's urology, but if the size is about up to 20 grams, it is grade 1, 20 to 50 is grade 2, 50 to 125 is grade 3, more than 125 is grade 4. So if it is like a small prostate on rectal examination, it is grade 1. The usual moderate one is grade 2. And a big one is grade 3 and a huge one is grade 4. So if it is like a cricket ball, then it is grade 4.
Amlesh sir, one question that has come from one of the postgraduates, Kiran Negi. He is asking that patient is already having an IPSS 21 in this patient. Giving an RT in this patient will symptomatically aggravate. I think we'll have to take that risk in this case. We don't have an option.
Yes.
Yeah.
Yeah. And no, first we are going to begin with hormonal therapy. And with hormonal therapy, the expectation is that there will be a good shrinkage of the prostatic tissue and there should be a good symptomatic improvement. And after that, the radiotherapy will be given. There may be an aggravation, but may not be also.
Yes, sir. Perfect, perfect, sir. And Prashant, we know that the EAU risk stratification is for both localized and locally advanced CA prostate. So one question has come from Dr. Ankur Akela. Is there really a risk stratification necessary in a patient of a locally advanced CA prostate?
In a locally advanced CA prostate, yes. So risk stratification, as I said, in locally advanced, in a localized prostate, with a grade group or I sub grade group of say one or two, you will have to decide whether to do active surveillance or not. That is based on the risk factors. That is one. In a locally advanced, the risk factor would determine whether you go for systemic intensification or not, whether this patient is going to also the duration of ADT. You are going to give RT, you are going to give ADT for how long. So that also, if it's a high risk patient, you would give it as Anand very rightly said, you go to 2 to 3 years. Whether you add systemic intensification, that also depends on these patients who have got a higher risk. So that is the role in the locally advanced TGPS.
Ankur, I think you got the answer for that. Although it's a locally advanced, still we do a risk stratification in this case because there is something called a systemic intensification therapy, and also thinking of continuing ADT for a much longer time. And there is a very high chance that you can miss a metastasis in this patient. As Prashant as well as Dr. Amlesh sir has been pointing out, a PSMA PET can pick up additional 20 to 30% chance of metastasis in the pelvis itself. This patient might have a pelvic metastasis, which is very likely. Amresh sir, one other question that has come up is they have given three different scenarios, our students. One is PSA is around 4 to 10 only. Of course, we have a high clinical suspicion. We always go with an MPMRI. What about a PSA which is 54? And what about a PSA which is 800? Should he do an MPMRI? First, PSA 54, should he do an MPMRI or simple MRI is enough, sir?
In fact, PSMA PET CT scan may be a better investigation in that, although there are not much literature available from the West. In our Indian setting, as Prashant already mentioned, that there is so much of experience of PSMA PET CT, and we know that if the PSA is 800, practically it is definitely CA prostate. In that, you may just take 2 cores to confirm that this is CA prostate. The idea of a PSMA PET CT scan is to have a baseline for follow-up. You'll know exactly what areas are involved, in the spine, what is the lymph node load, and for follow-up purposes, that would be quite useful. The other advantage of PSMA PET CT scan in this situation of PSA of 800 would be if there is a high risk of paraparesis, then that has to be addressed, because a patient who has a PSA of 800 will have a very poor prognosis. And if a patient dies with paraparesis, the ultimate period is very difficult for the patient. And if you can prevent a paraparesis by diagnosing the spinal involvement, and either by combination of hormonal therapy, radiotherapy, or by fixation, that is something which needs to be done very aggressively and on priority basis.
And
MPMRI in that situation has no role. MPMRI is for early pickup of CA prostate.
Perfect.
on
Perfect.
that note, also the students must be aware that now we have got PSMA PET guided biopsies also available. So many certain institute like Search Institute, My Institute, they have started doing robotic transgluteal PSMA PET guided prostate biopsies. So that is also something which is coming up now. Yeah.
Yeah, great. So I think the candidates got the answer for that. With such high PSA value, PSA values, an MPMRI may not be very useful to you. Probably a simple MRI can tell you what is the extent of the tumor, and more than that, a PSMA PET, if it is done, it gives you a very clear idea of whether about the metastasis or the risk of developing a fractures. These things. So the other question that has come up, I think Prashant, you can take this question. What is the role of channel TURPs in these patients? If this patient goes for a retention during the course of management, Or do you routinely advise a channel TURP in patients with CA prostate? What is the role?
So we do not routinely advise. So this patient, so somebody who has got refractory retention, suppose somebody who is in retention, who is currently on a catheter, he has failed a catheter-free trial, and then is undergoing therapy. So then we consider channel therapy. That is number one. But most of our routine practices we start, like sir said, I'll give ADT. I'll wait for shrinkage of this prostate, and maybe after a month I would remove and give another catheter-free trial. So post ADT, post shrinkage, if this is not responding, only then I would think about doing a channel TRP, because if you give RT after that, post TRP, RT would have again more severe consequences.
So post ADT, how many months, Prashant, you would like to wait, or in terms of 4 or 6 weeks?
I give a catheter-free trial at 1 month. If it is not successful, I wait for another 2 months, so 3 months. If not, then only I'll think about doing it annually.
And Prashant, any role of intermittent androgen deprivation therapy
No.
nowadays? No.
No.
It's gone, almost gone. Okay. What is the ideal time to repeat the serum PSA values if it is raised during the first evaluation?
Ideal time to repeat. So generally we follow them up with a 3-monthly serum PSA. So there is bound to be flare-ups. So we know that when you give RT, so there is bound to be flare-ups. So we have to keep in mind that these flare-ups, which would lead up to about 15 to 20% rise in PSA. So that we have to keep in account. And even if that occurs, we should keep our calm and then repeat it 3 months later. And we expect this flare up due to inflammation to settle down, and then the PSA would start falling. Yeah. 3 months.
No, I think the question was regarding a confirmatory PSA. Supposing the patient comes with a PSA of 5.8.
Okay.
Will you wait or will you advise immediately? I
So
think
we
the answer is immediately.
Yeah.
What is, because these fluctuations, they would occur if the patient is actually having fluctuating PSA, it would be occurring within days. But if it is a progressively rising PSA, then that is confirmatory PSA. You need not wait for 2 weeks, 3 weeks, etc., etc. You just want to give the patient an advice regarding MP, MRI or not, or biopsy or not. Then you can do it immediately. I mean, patient comes to your OPD, you advise that you get it done before the next OPD and come back after 3 days.
So this is what Chengalvarayan sir I was talking about earlier, that when sir is talking about the diagnostic PSA. So there you do a PSA, you get a confirmation immediately just to see that the two labs, both the reports are same. But if you have a doubt due to any reason PSA is elevated, if you have doubt about prostatitis, doubt about anything which could false elevation, then you wait slightly longer. Otherwise, if you're only getting a conformity, like sir said, you can get it immediately. You can get it the next day also.
Amlesh sir, in your experience, what will be the usual rise of the PSA value following an RT? And in your experience, when does it hit nadir? Because we have read theories, but you are more practical. You have seen a lot of patients.
Actually, there will not be much rise because patient will have received ADT for 3 months before radiotherapy, and the PSA would have already come down significantly. From 45, I expect the PSA to come down to about maybe 4-ish in this particular patient. And then after that, usually during radiotherapy, PSA is actually not repeated because PSA would in that situation be done usually at 3 months. If not at 3 months, not before 6 weeks. So we don't actually see a significant flare. Even if there is a little bit of flare, number one, it will not be very significant. Number two, it will most probably not be picked up because the PSA is not done as frequently when the patient is subjected to radiotherapy.
And the nadir values, sir, usually how long does it take in your practice?
Nadir value should come down to 1-ish. In this particular patient, it may not come down to 1. It may remain at 1 or 2. That is why, the Phoenix criteria is that nadir value for that individual patient plus 2. That is what is considered as. So obviously the nadir value varies from patient to patient. That's the reason why this definition of of PSA recurrence.
And
And but yes, I would expect that with this, it should come down to around. It should, in most radiotherapy patient, it comes down to around 1-ish, maybe 1.5. So
what Chengalvarayan sir is asking is that how long it takes, sir, for to reach nadir in general after RT.
Correct. That's what I want.
3 months is the ADT, then about 6 weeks is and then after another 6 weeks, this is done. So you can say around 6 months or so, it should reach a nadir value, and then it may keep on falling.
Okay.
It may keep on falling, and therefore the nadir value is the one which is the lowest value.
Okay.
Prashant, generally these classes usually we wind up around 8:45, 9. But today, a lot of questions are still falling in. Another 5, 6 questions have come. I think, and this is one of the maximum attended classes actually which we had for the last 7 or 8 weeks. Prashant, they are asking you a tough question. This is a little advanced CA prostate with bladder infiltration also. Now the patient comes with the retention of urine. You are not able to channel to ERP or something. Would you still go for an SPC in this situation? I don't know who asked this very tough question to you. What? Yeah.
SPC versus keeping urethral catheter.
Yes.
I would err on the side of keeping urethral catheter.
Urethral catheter.
Yeah, rather than subjecting. Sir, any thoughts, sir? Amlesh sir? I would also.
Yeah, my answer to this is there is no contraindication for doing an SPC in a CA prostate patient. In a CA bladder patient, SPC is contraindicated.
And yeah, fine, effective. Can we directly? Fine. The other question, I think Amlesh sir has answered this question. This question asked by Dr. Gulshan Kumar. Can we directly go for a PSMA PET in patients with suspicious of metastasis? I think sir has answered this question. If you have a very high PSA, instead of wasting much time, you can go straight into a PSMA PET.
Yes.
Yeah. The other question is, if it is an NET tumor like a small cell carcinoma, what will be your take on this patient?
NET generally occurs in a hormone refractory situation. So one of the mechanisms by which it becomes hormone refractory is conversion of acinar adenocarcinoma into NET. And NET responds very poorly to hormonal therapy. And NET has a poor prognosis. If any response has to come, it will come with chemotherapy.
Great, sir. Prashant, I think a lot of thunderstorms around your place and the electricity.
So that is why I had some
And we won't hold you for a long time. 1, 2 or 3 more questions coming up. Sir, there's one scenario has been given by Dr. Amitav. He says the PSA value is 2000.
Okay.
The patient has come to you. PSA value is 2000. And what next immediately we'd like to do? Start this patient immediately on Degarelix, or we'll do a biopsy, we'll do investigation.
So again, like Amlesh sir told, if there is any pressing cause, like patient has got any paraparesis, paraplegia, impending paraplegia, those are the indications for immediately intervening. Having a PSA 1000, 2000 doesn't really, as long as patient doesn't have that pressing need, there is no need. So indications to do pressing need are 2. One is impending paraparesis or impending retention of urine also is written. So these are the 2 textbook reasons when you should consider doing a upfront Degarelix you have to give. Otherwise, there is no pressing need. And if you can get a biopsy done, it need not be a truss-guided biopsy. You find a nodular prostate, do a finger-guided biopsy, wait for the report, and then you can start treatment. Yes.
The next question, Prashant, that has followed that is from one Dr. Kuppan from Chengalvarayan Medical College. What Kuppan is asking is, in case if you decide is going to be an impending paraparesis, would you prefer to do an orchiectomy or would you prefer to go for a Degarelix?
So I think Degarelix is equally good, but I have nothing against orchidectomy. So many of my patients undergo orchidectomy because there is no intermittent ADT. Once we do orchidectomy or once you start ADT, it is generally continued for life. So there is no harm or there is nothing against doing orchidectomy, but Degarelix is equally good for impending paraparesis cases. Yes.
Perfect. And Prashant, I have
orchidectomy is significantly cheaper Similar
Yeah.
teaching.
I have to add one this thing, sir. It's an observation which I had. 2 years back, I had one patient who's clinically normal. It felt like a BPH only, but his PSA value was 2000 reported. So we were really confused what to do. Then I had to talk right away to the lab, and they said, "Sorry, sir, we have not put that dot. It is 2.00.
Oh my
We
God.
put it instead 2000." So we were in real confusion of seeing this. This can also happen when you have a high PSA values. Now we'll take only three more questions. There are a lot of questions
Another
coming.
small point, earlier these PSA machines they were not highly sensitive PSA machines. So they used to give greater than 100. You don't know what
Correct,
it
correct.
is, whether 800,
We
1000,
see a lot of values like that.
sensitive machines were getting these reports here. Okay.
Correct, correct, correct. A PSA of 7, you are suspicious of malignancy, but your trust is negative, MRI is negative, everything is negative. Would you like to proceed? How would you like to proceed, Prashant?
So in
Always
this
in the gray
scenario,
zone.
there is something called PSAD. You do a PSA density, and that has come up to help in this scenario. So get an MPMRI done. MPMRI gives you a size estimate. Based on the size estimate, you find what is the PSA density. And when PSA is in this gray zone, and when there is MPMRI says it is maybe grade 2, PIRADS 2, PIRADS 3, then whether to do biopsy or not, you will have to decide doing a PSA density. And so if PSA density is somewhere between 0.1 to 0.2, if it is more than 0.2, definitely go ahead and do a biopsy. Less than 0.1, you can wait. 0.1 to 0.2 becomes a gray zone again for PSA density, but PSA density can help us in that.
So when you're still suspicious of malignancy, it stays in the gray zone. Your options is to add more investigations like PSA density, or you can take in the prostatic health index, or even you can go for your PCA. I think all these things are additional facts when you still suspect that there is a malignancy possibility in
So
this.
EAU guidelines currently mentions PSA density and how to decide based on PIRADS and PSA density. So that is there in EAU 2025 guidelines.
Yeah. So we'll take two more questions and we'll finish the session. I think this is a little straightforward question from Dr. Taragan. What is the role of docetaxel? When do we advise docetaxel? Amlesh sir, can you take it?
Yes, docetaxel is advised in a metastatic setting where the load of metastasis is high. And if there are visceral metastases, then again docetaxel is to be preferred. But in most situations, the abiraterone is used as an additional therapy in addition to ADT in the metastatic setting.
Thank you, sir. So the last question, yeah, what is the current role of treatment for neuroendocrine tumors, Prashant?
So as sir has already mentioned, neuroendocrine chemotherapy is the go-to option. So in neuroendocrine, there are two things that we should remember. That PSMA PET will not show it. So these are the subgroup patients where an FDG PET has to be done to see whether it is metastasizing and spreading. And again, chemotherapy is the option. So yeah, so this apart, something that students have missed or something that they will need to know in locally advanced disease is the role of this adjuvant therapy versus early salvage. So that's a big discussion in itself, and that also students should read about whenever they're preparing for
Good, sir.
this.
So just before I close, one more question from Gulshan Kumar has come. I think we'll put the question to Anand and Durva.
Yes.
They have asked, when do we start agonist? When do you go for an antagonist? You're given the options with you. When do you go for an agonist? When do you go for an antagonist?
Agonist, sir,
Yeah, your level question.
yes. Antagonist usually when there is impending bone compression or during those times we give antagonist, but when there is no significant spinal cord impending compression or significant metastatic complications which are impending, then we usually go with LHRH agonist, GnRH agonist.
Why generally
If
agonist?
you want to get a rapid response, we want to bring down the PSA rapidly, then we usually go for antagonist.
Why these agonists are generally preferred over antagonists?
Sir, One is
They say we use antagonists only in these situations. So why agonists are preferred more?
Very simple and practical answer.
they're cost-effective ones, and
No, I think many of the antagonists have now become cost effective. These companies have brought the rates down like anything now. When it comes to a long-term treatment, you give depot injections once in 3 months, once in 6 months are also available. You don't have to worry about the compliance in these patients. Correct. So antagonist is something which is preferred when you don't want the flare phenomenon. So the initial period when you want the PSA to go down and there is an impending fracture or something, you want to go with an antagonist. You don't want to go with an agonist. After that, you can decide whether you want to continue an antagonist or an agonist. Uh, I think we'll close the session with that. The last question, I'll give it to Anand. Anand, how many
Yes.
weeks do you really want to wait? Because you are the one who wanted to say that I will not do an MP-MRI, I'll go for a trust biopsy. How many weeks you will want to wait to do an trust biopsy? MP-MRI has been done. That is, otherwise, what they're trying to say is,
Yeah, MPMRI for sir.
how time you have to delay the MP-MRI. That is, I think that is what the question is intended for.
So at least 6 weeks we will delay the MPMRI to get the local T staging done.
So now, do you agree that most of us are of the consensus that we want to do an MP-MRI before the biopsy?
Yes, yes.
Good, thank you.
Yes.
Amlesh sir, it has been absolutely wonderful, sir. So because your presence as a very experienced person and as a director of the AIIMS New Delhi has added a lot of value to our program. We had the maximum number of attendees today and the maximum number of questions. The program has gone almost up to 9:15. Thank you very much for your presence, sir.
Thank you. It's my pleasure. And I'm not the director of AIIMS. I'm only head of the Department of Urology.
But your level of expertise was far beyond any post or any positions. I have seen you in many of the exams. The quality of you, the way you ask questions, and the way you have interacted with most of us, it was absolutely fantastic. Absolutely fantastic.
Thank you.
Prashant Nayak on the other side, sir, is a very good friend of mine. He is very tall, stands 6'5". He doesn't tall. He's just sitting there. Actually, Prashant is a very good friend of mine. He was ready to accept immediately when I said Prashant is doing a lot of uro-oncology work in his place. And one thing which Prashant, can I say that? Prashant told me was immediately he said, "Yes, sir, I'm ready for this program." Then I told Amlesh Seth sir on the other side, "Sir, you have put me with the doyen of urology on the other side. What will you do with uro-oncology with him?" I said, "No, Prashant, you are also very, very good. And both of you would make a beautiful combination." I think both of you have done a wonderful job for all the students here, sir. Guru, you had been very much particular that you wanted to have this program done. And you wanted this particular session. And yeah. I wanted this particular session. And Anant also, when I called him just 2 days back and asked him whether it's possible for him to join, he immediately agreed and joined. So thank you, Anant. Thank you, Guru, also for joining. And Surender Prashant on the other side is my postgraduate who has been with me for the last 7 weeks. In fact, he has not allowed any other postgraduate to come in. He said, "I will only do, sir. I'm so much interested in this." That kind of interest Surender is doing on the other side. And Mankind Pharma, not a very big pharma in the urology setup. But when I told them, "Is there a possibility for you to help us in this program?" They said immediately yes. And they are doing a lot of work extending this opportunity for students. So thank you, Mankind Pharma also. So once again, I thank Dr. Amlesh sir, Dr. Prashant Nayak, Dr. Duruva, Dr. Anand, Dr. Surender, and Mankind Pharma Rushi and your team. Thank you very much for a wonderful, wonderful day today. And we'll continue to have this program. One more rotation, Dr. Prashant and Amlesh sir, will take you in again. I will be very happy if you are ready to consent for one more chance.
Looking forward.